Hello, I've seen we have a lot of participants this afternoon. We have a friend from India, a friend from Belgium, a friend from Germany, Russia, and so on and so forth. It's a good number of participants. My name is Leonard Banza. I'm an orthopedic surgeon working in Malawi at Kamuzu Central Hospital. I will welcome you all to this second AO Alliance Foundation webinar on treatment of pediatric elbow injuries in lower income countries. And on this podium, I'm not alone. I'm with my colleague, Florent Lekina, who will be our moderator today. Florent?
Thank you, Leonard. Hello, everybody from all around the world. My name is Florent Anicet. I'm working at the General Hospital in Yaoundé. On my role today will be to collect your question and try to get an answer on it with the accompaniment of Leonard. Okay, Leonard, go ahead.
Okay, for the following 45 minutes, this is my outline. I will say a few words about the AO Alliance Foundation, and then we'll move into the treatment of pediatric elbow injuries in the lower income countries. Thereafter, we'll have a period of live questions and answer. Then we'll have an offline chat to answer further questions. AO Alliance Foundation is a developmental non-profit organization very dedicated to improving fracture care in low-income countries through a local capacity building. And this foundation is very committed to achieve this through education, research, clinical support, but also through professional development of healthcare personnel. Let's move into treatment of pediatric elbow injuries. And I would like to start with this case. This is a 6-year-old boy who was helping his parent in the farm and fell on an outstretched arm. On the physical assessment, he had a swollen elbow, but the neurovascular was intact and he was not able to use his arm. Now, at the nearest health facility where they stayed, there was no treatment of such kind of injuries. No splinted was provided. So now the boy and the parent, they had to walk 2 days just to reach the main road. And from there, they got the bus to go to the city. And they reached the fracture clinic on day 5. Now, if we say this boy is lucky, it means this boy was supposed to be admitted and treated properly. But if the boy is unlucky, he might end up with a lifetime disability. But it shouldn't be a matter of being lucky or unlucky. This boy deserves a better treatment. So what are our learning outcomes? At the end of this webinar, we should be able to recognize and diagnose elbow fractures and related injuries in children and adolescents, and explain the serious nature of these injuries and how they can be easily overlooked. We should be able to define a treatment option and attitude in low-income countries with very limited resources. And above all, to prevent, identify, and manage complications and late presentation, as it's common in our setting. These are general facts regarding pediatric elbow injuries. They make up about 65% of all pediatric musculoskeletal trauma. And as you know, in the lower income countries, even getting an X-ray can be very difficult. Sometimes one view, it's enough to establish the diagnosis. Compartment syndrome can happen, but it's quite rare. Physical examination is very, very important. As you know, a child with an elbow fracture, he doesn't want to move his limb. The swelling, it's a common feature, but you need to complete your neurovascular examination. You have to palpate the arm and the forearm for sign of compartment syndrome. It is very important to differentiate between an elbow dislocation and an elbow fracture. And this is how you can do it. When you have an elbow in extension, you have three landmarks that you need to consider: the medial epicondyle, the olecranon, and the lateral epicondyle. With an elbow in extension, these three landmarks, they are all on the same line. But with an elbow which is flexed, the three landmarks form an isosceles triangle. Now, if you have a displaced fracture, remember that the three landmarks, they don't move in relation to each other. The triangle will be still the isosceles triangle. However, the triangle will tip backward, but it's going to remain the triangle, which is very different with the dislocation, where all these points will be disturbed and you can't have a triangle. And it's very important to differentiate an elbow dislocation and an elbow fracture. Neurological examination. As you know, the child is in pain, the child doesn't cooperate, so sometimes it's a bit challenging on how to examine the neurology. But we always ask the clinician to be very gentle with the child. And remember that all three nerves can be involved in these injuries: the radial nerve, the medial nerve, and the ulnar nerve. And what we do most of the time is you don't touch the patient. Yourself, you show what the patient, what the child is supposed to do. And most of the time it works, as long as you don't touch the child. You start with the radial nerve by asking the boy, to extend the thumb, and you show it how to do it, and you will follow. And you move to the medial nerve. You ask the boy to show you the O sign. By doing the O sign, you flex the thumb, and the boy will do it. And then you move to the ulnar nerve by showing how he can do abduction and adduction. It works. It's just a matter of being very gentle with the boy. And don't touch him or don't touch her, but just show you on your own, and you will just follow what you are doing. Then after the clinical assessment, you need to move to the radiological assessment. You can't treat an elbow fracture without an X-ray. Most of the time, you get an epi and the lateral view of the elbow, but also you need to to consider the center of ossification, because you are dealing with a growing child, which is different from an adult. Now, let me ask you this question, and please, I will ask you to vote. To avoid cost and pain, a second X-ray of the elbow is not necessary if we see a displaced fracture around the elbow in a child on the first X-ray taken. Yes or not? Please do vote. Great. So it's 50-50. 50% said yes and 50% said no. But remember what we said. Sometimes it's very difficult in our setting because of the cost of the X-ray. It's very difficult to get both views. But you need to have the knowledge and you need to be educated, just to make a diagnosis on one X-ray. Then you move on. You need to check what we call the Bowman angle, which is an angle formed by a line through the axis of the humerus and another line that goes through the physis of the capitulum. This angle is between 70 and 75. It's less than 80, and it varies, according to the children. Then there is the radiocapitular line. This is a line that is made on the axis of the radius, and this line should intersect the capitulum on the lateral view. Then after that, you assess what we call the anterior humeral line. This is a line drawn along the anterior humeral cortex. Again, this line should pass through the middle or the middle third of the capitulum. And this varies in very young children. So as you can see, all this line we are talking about, they are very, very important to help you assess an X-ray and see if there is a fracture or not. And there is what we call the capitulum angulation. As you can see on this X-ray, the capitulum is like a cap and is tilted anteriorly of about 30 degrees. That is the normal X-ray. Then you will remember that we are dealing with a child, a growing child, where some of the bones, they are still cartilage. So there is one way, easy to remember this ossification center. And the mnemonic that we use is CRITOE. C for capitulum, R for radiohead, I for the internal epicondyle or medial epicondyle, T for trochlea, O for olecranon, and E for lateral epicondyle. Now, we are going to cover, for the time remaining, 3 of these injuries because they are quite common: the supracondylar fracture, the lateral condyle fracture, and the medial epicondyle fracture. Let's start with a supracondylar fracture. There are some general facts we need to know about these fractures. They are most common around the elbow in children. It's about 60%. 95% happen in extension type. And the mechanism of injury, the common mechanism of injury is a fall on an outstretched hand. And why did it happen, or does it happen in children? It's because of the ligamentous laxity and the hyperextension of the elbow in children. Those are the mechanical factors that are prone to this type of fracture in children. And supracondylar fracture can happen with other injuries around the limb. So you can have associated fractures such as distal radius fracture or fracture of the forearm. And that's why it's very important not just to concentrate on the elbow, but you need to assess the whole limb. The most common classification we use is the Gatland classification. It's very simple. It's 3 types: non-displaced, type 2 displaced with the posterior cortex which is intact, and type 3 is completely displaced fracture. But also, because we work together and collaborate with the AO Foundation, there is a classification. We classify this in complete and incomplete fractures. And then you can see how complex sometimes this fracture can be. Now, let me give you this case. This is a supracondylar fracture. How would you treat these injuries? Of course, clinically, the skin is intact, the neurovascular is okay. How would you treat these injuries? A, straight arm traction only. B, close reduction and long arm cast. C, close reduction and percutaneous pinning. And D, minimal lateral incision for open reduction and K-wire fixation. Please vote. Okay, I can see the result. 80% of the participants, they have chosen C. It means close reduction and percutaneous pinning. That's correct. That is the gold or standard of treatment of these fractures. But remember, we are in the lower income countries where most of these hospitals, they don't have the CM machines. So what will we do? What are you going to do in the lower income countries? But I agree with you, C, that is what we can do. But if you don't have CM, what are you going to do? So maybe we're going to discuss this further in our time for discussion. Let me suggest you this algorithm, especially if you don't have a CM in your hospital. So what about this? You have a child with a supracondylar fracture, the arm is swollen, then what you do is you assess clinically the patient, you put a straight arm traction for 2 or 3 days. Then after that, when the swelling subsides, you take the patient to theater and you do a mini open to reduce and fix it with K-wires. And 3 to 4 weeks later, you remove your pin and allow the patient to start moving his elbow. So, do you agree with this treatment algorithm if you don't have an access to a CM? Yes or not? Please vote. Okay, so 70% of the participants have said yes. Now, we are going to discuss maybe further. So if you agree with this algorithm, so it means that you will be operating all your supracondylar fracture, all your children, you have to operate them all the time. We are going to discuss. But let me remind you that you need to submit your question to our moderator while I'm presenting this talk. There was, in 2005, there was a paper was talking about supracondylar fracture, where children were treated just by elevation, straight arm traction, and these were the conclusion. They said elevation and straight arm traction was the treatment of choice for children under the age of 10. And also, it was found that the result was as good as surgery, and they didn't have any iatrogenic complications because there was no surgery. So just to remind you that this was a paper, 2005, and these were the results. But also, don't forget about blunt technique for close reduction is still valid. And personally, I always and I continue using it because I found it very, very interesting. Just to remind you, this technique, you apply a traction in extension for about 3 to 5 minutes. And remember that you can't do it alone. You need someone to help you while you're applying the traction. And while you are still applying the traction, you need to correct the varus and the valgus deformity that you will be seeing. And thereafter, you flex the elbow at 110 or 120. While you are flexing, you are pressing on the olecranon with your thumb. Then remember, if you had a posteromedial displacement, remember to pronate your forearm while you are flexing. And if you had a posterolateral displacement, remember to supinate your forearm while you are flexing. And it works. These are some traps when you are dealing with supracondylar fractures. Malrotation causes angulation. And unfortunately, the distal part, it's very difficult to visualize on an X-ray to see if there is malrotation or not. But this will be the cause of the angulation. Watch pink hand and be aware of pale hand. Remember that fractures that we open, they become stiff. Always encourage the active movement than passive. And in children, there is no need for physiotherapy. Just we do encourage active range of motion. And let's go to a lateral condyle fracture. And this is case 2. This is a 3-year-old girl who fell onto her outstretched hand. Now, this is the X-ray. Clinically, the skin is intact and the neurovascular is okay. The question I would like to ask you is this one. Should you be worried about these injuries? Yes, no, maybe, or not sure? If you can vote. Fantastic. 8% of the participants said that there is a need to worry about these injuries. Regarding the same patient, let me tell you that the gap in between the fracture is more than 2 millimeters. Now the question is, how would you treat this fracture in lower income countries? A, by sling and early active motion. B, cast immobilization. C, cast immobilization with weekly X-ray control. D, close reduction and long arm cast. E, minimal lateral incision for open reduction and K-wires. Please do vote. Yeah, I can see there is a gap, in your answers, and 6% they have chosen E, minimal lateral incision for open reduction and K-wires. And I will totally agree with you on this. Now, when you do your ORIF, you put your pins. What will be the clinical outcome? A, anatomically healed fracture. B, delay union. C, cubitus valgus due to non-union. Or D, cubitus varus due to avascular necrosis. And let me remind you that on the X-ray, as you can see, the yellow arrows show the correct position for the two K-wires if you want to achieve a proper fixation. But do vote for this question. Yeah, so 50% said this patient will end up with a cubitus valgus because of the non-union. It's controversial because when you open and fix it, it's because you want to achieve anatomically healed fracture. Now, if you fix it and still you end up with a cubitus valgus, so what is the point of fixing it? Maybe we can come back later again and discuss about this. Talking about lateral condyle fracture, there is a classification that we use, and this is Jacob classification, which that divide these fractures in 3 stages: stage 1, stage 2, and stage 3. But the key prognostic factors, as you can see in this classification, is the presence or the absence of medial cartilage hinge, like in type 2 and in type 3. The cartilage hinge is broken, and that play a big role in the prognosis when treating these injuries. Now, this is the treatment principles when you are dealing with lateral condyle fracture in low income countries, where, I said again, we don't have the CM machine. When you have a minimally displaced fracture, less than 2 millimeters, we just apply a long arm cast for 3 weeks, and it's enough, and you can get an X-ray control. But when you have a displacement of about more than 2 millimeters, you have to open it and reduce the fracture and fix it with K-wires. Then you can pull the pins after 4 weeks and encourage active range of motion. Remember that we are not able to do arthrogram, but also, oblique views is not in our routine. But if you can do an oblique views, that's fine. But most of the time, we don't do oblique views because of the resources. Late presentation, it's common. What do we do when a patient comes to you 12 weeks after injuries? Of course, non-union is expected, plus avascular necrosis of the fragment. But we do try to put the emphasis on the function than the cosmesis. And we just leave it alone and observe, unless if it's symptomatic. If it's not symptomatic, the function is okay, we just leave it alone. This is the final result of our case. As you can see, the deformity is not progressive and will not restrict the function of this hand. And let's move to the medial epicondyle fracture. Now, this is the case and this is the X-ray. Clinically, the skin is okay, neurovascular is fine. How would you treat these injuries? A, long arm cast only. B, close reduction and long arm cast. C, close reduction and percutaneous pinning. D, open reduction and internal fixation. Please, if you can vote. Okay, that's very interesting. 50% of the participants, they say that they need to open, reduce, and internal fixation, which is okay. But just let me remind you something on this X-ray. As you can see, when we have discussed about the assessment of our X-ray, remember the line we're talking about, the anterior humeral line and the radiocapitellar line. So if you see on this X-ray, we are dealing with an elbow dislocation. Not just an elbow dislocation, but the fragment is in the joint. So it's something very, very important to consider when you are dealing with an X-ray. You need a proper assessment. Otherwise, you miss it. So these are the facts we need to understand about the medial epicondyle fracture. It's common. It's something like 15% of the fractures around the elbow, and it happens in children between 10 and 14. Most of them, this fracture, they are extra-articular. They are avulsion fracture due to a valgus stress. Let me emphasize on this. You need to rule out an elbow dislocation because in 50% of these injuries, they are associated with elbow dislocation. And in 20%, these fragments, they are incarcerated into the joint. So you need to watch out. Otherwise, you take the patient to theater, you reduce your elbow, and with the fragment within the joint, so you are not helping your patient. Watch out. How do we treat the medial epicondyle fractures? If they are minimally displaced, long arm cast for 3 weeks, it's enough. But also, even for those which are displaced between 5 millimeters and 1 centimeters, we do still have good result with non-op treatment. The only case where you can operate is when the incarceration of the medial or the fragment is in the joint, but also when you are dealing with an open fracture, then you can open. But most of these medial epicondyle fracture can be treated non-op and still have good result. Remember the robot manipulative techniques for the incarcerated medial epicondyle fracture, because sometimes when the fragment is incarcerated, before you decide to open, you can try the robot maneuver. You put your elbow of the patient in extension with a valgus stress around the elbow. While you are doing so, you supinate the forearm and start simultaneously dorsiflexion of the wrist and the fingers. In 40 to 50% of cases, this maneuver is successful. But when you fail, and then you can open and remove it. These are the overall complications of pediatric elbow fractures. Some of them, they are common. Some of them, they are very rare. Malunion is quite common. Stiffness and extension loss, it's common. And compartment syndrome is not common. Myositis ossificant, these are not common. Because of the late presentation, we do have stiffness and loss of extension motion. There are some socio-economic consideration in the lower income countries you need to take into consideration. Consider the culture and social behavior of the community where you are living. Sometimes that you may see this child just once and the follow-up patient can't come back again. So you might just see him once. So you have to take the chance to treat this patient better. We do have challenges with our equipment. We don't have C-arm, we don't have radioscopy, we don't have portable X-rays machine, etc., etc. And sometime without radioscopy, open surgery with minimal incision will be indicated in some displaced injuries. We know that we are having financial resources challenges, but the treatment has to do with our knowledge of the injuries, even if we don't have, the resources. In another word, lack of resources shouldn't be an excuse to mismanage this patient. At least in our setting, we can have skin traction, the reduction technique, as part of our skills, but also smooth K-wires. They are easy things to find. These are the norm for many of us. Patient comes too late. Patient has been mismanaged somewhere, and then when they feel like doesn't work, then they send them back to you. No X-ray can be obtained. These are the norms. Then your treatment must be the definitive treatment. Even if you don't have enough resources, it's very important that you use your knowledge to correct these injuries. There are some treatment guidelines in lower income countries, and I will remember these rules by Dameron and Thompson. They do still make sense to me. He said the simplest may be the best treatment. We don't need fancy. If it can be simple and have good result, that's enough. Whenever possible, the initial treatment should also be the definitive treatment, because these patients sometimes they go and they don't come back. Try to correct the alignment of the fracture, because we don't rely much on the remodeling process. If a patient has a decubitus varus, it's not going to change. It's not going to remodel. It will grow up with decubitus varus. So try to correct the alignment while you are treating these fractures. To some of us, this theater is still a dream. Of course, it's a wishful thinking, but we can't all have these theaters in our setting. Now, I will give the time to my colleague, Florent. Probably he had some questions for discussion. Florent, over to you.
Okay. Thank you, Leonard. We have a lot of questions. So since we cannot answer to all the questions, I did a selection of some good questions that I will try to discuss with you. The first one is a question about the posterior access for the pining. Do you have any experience of it, and do you think, what is your opinion about this posterior access? It is better than the lateral one, or what do you think?
Let me just try to understand the question. He said there is posterior approach, isn't it, during surgery?
Yes, during surgery.
Okay.
During open surgery.
Okay. If you understand your anatomy, the blood supply to the distal part of the humerus is provided by the soft tissue on the posterior aspect of the forearm, the posterior aspect of the arm. So what they do advise is not to do a posterior approach, because you can damage the blood supply to the fragment. What people do advise is to do a lateral approach and maybe medial approach, so that you get access to the fracture, you reduce it, and you put, cross K wires, maybe lateral K wires accordingly. But in terms of approach, try to avoid the posterior approach because of avoiding to compromise the blood supply to the fragment.
Thank you, Leonard. We have, since you have started now speaking about the technique of the car wire, we have questions about this technique in our limited resources. A participant is asking about the method of choice for the car wire. Did you think they must be crossed, or do you think the lateral car wire are sufficient, or do you think medial and lateral car wire is necessary? What is your opinion?
Merci. Thank you, Florent, for these questions. And I need to be honest with you, this is a very controversial question. If you read papers, people will tell you that, cross K wires is the best. Others, they will tell you that you need to put two parallel lateral wires to avoid injury to the ulnar nerve. Other people will tell you that you need to put two parallel wires, and on the lateral side, and one on the medial side. So as you can see, it's very controversial. Okay, it's very controversial. Now I will tell you, if I have to operate this in our setting, supracondylar fracture, I make an incision on the lateral side and on the medial side. I need to see the ulnar nerve and to protect it. And once I'm happy with my reduction, and I put wires both sides, and I cross them, and that's what I do. But as I said, it's controversial. Yeah.
Thank you, Leonard, for your response. Now another participant want to know if how will you position the elbow after the pinning in a lateral condyle fracture? It is straight or it is flexed? What is your opinion? What do they do?
Once you fix the lateral condyle with wires, post-op, I just apply a posterior splint with the elbow flexed, 90 degrees, and I keep it for 3 to 4 weeks. And after that, I remove the K wires and then encourage the patient to start moving his elbow.
Yes, Leonard. A particular point by the treatment of these elbow fractures is the injuries of the ulnar nerve. Can you tell us something about it? What does the literature says about the percentage of the ulnar injuries?
You mean the ulnar nerve injuries in which type of in which type of fracture?
Probably the medial condyle injuries.
Oh, the medial condyle fracture. If you don't open it, if you don't open the fracture, it's very rare to have the ulnar nerve injuries. I know that you can have complication of ulnar nerve injuries as a part of the lateral condyle fracture, which is complicated with, for example, cubitus valgus, and later on you can have ulnar nerve injuries. But also sometimes with a medial condyle fracture, you can have a kind of scarring, around the elbow, and you can have, ulnar nerve problem. But it's quite rare. It's quite rare. I read it about it, but it's not common.
Thank you, Leonard. Another good question, still we are here in low-income countries, is to know, in case of the treatment of this supracondylar fracture by straight arm traction, how long will you keep the traction applied, and at which time will you convert to a long arm cast?
What we do, for example, in my hospital, we keep the straight arm traction for 4 to 5 days, just for the swelling to subside, because the children they come in with a massively swollen elbow, and you can't start manipulating a swollen elbow like that. You can compromise the blood supply. So you keep it 3 to 5 days, and once the swelling subsides, then you can take the patient to theater and manipulate the fracture. It works.
Okay, thank you, Leonard. We are going to take one more question. It is a question about what is a question about the fixator, the external fixator. Do you think there is an indication to use the external fixator by the treatment of supracondylar fracture?
Treatment of supracondylar fracture with external fixators, unless if it's a complicated fracture. Otherwise, maybe if it's an open fracture, it's even better to take a chance and to fix it straight away. But in children, unless if it's a very bad fractures with soft tissue loss around the elbow, something like that, you can do maybe external fixators, and then but it's quite rare. I haven't done it. I've done it in adult, but I would just advise maybe if you have a complex fracture, maybe a traction you can do, olecranon, maybe traction for some time. Yeah.
So another important question, Leonard, is about puslet lamp. What do you think? What will be the approach? What can you propose a algorithm for the treatment for puslet lamp after these supracondylar fractures?
You mean if the patient has got a pink hand, but it doesn't have, you can't feel the radial pulse? That's what you mean?
Yes, that's there is without a pulse.
Okay. So if I have a patient with a pink hand and I can't feel the radial pulse, I need to observe that patient. I'm not going to rush with this patient to theater. I will just observe this patient, because for me to rush this patient to theater, I need to consider other signs and symptoms. For example, if the patient, the hand of the patient is still warm, okay, for me it's still a good sign. If the patient doesn't have pain on passive extension of the fingers, for me, this is still a good sign. If there is no sensory loss around the hand, for me, it's still okay. If the capillary field around the fingers are still present, I'm not going to worry about lack of, radio pulse. I will observe this patient.
Thank you, Leonard. Now, can you tell us something about the technique of applying the forearm traction? There is a question from a participant who want to know about it.
Applying a traction to the forearm, it depends. There are some people, they have got sophisticated device, in their hospital. But for us, we just use the IV drip stand, and and we have the sticky plaster, which you are going, to put not above the elbow, but it must be below the elbow with a bandage. And then some people, they can use like in a skeletal traction of the leg, they can use a weight. Sometimes if you don't have a weight, you can just tie your bandage at the drip stand, and as long as the arm is not touching the bed, but also as long as it's not pulling too much, the child, and make him uncomfortable, and that's it. And then you wait 3 to 4, 5 days, and until the swelling subsides.
Okay. A very important question is about the time to start the elbow movement after the removal of the carrier. Can you tell us something about the time frame?
I always encourage my patient to start moving the elbow after I've removed the cast. They don't need to wait. I don't send them for physiotherapy. I just ask them to start moving, active exercise, and it works. And in children, it's very fast, because somehow they will go out because they don't feel pain, and they will start trying to play around, and they will start moving the elbow. Yeah, so that's what I do immediately after I've removed the slab. I advise them to start moving the elbow.
So now to the complication. Leonard, what do you think? First, what is the age to correct any valgus or varus deformation? And then, what do you think generally about this osteotomy?
Again, this is a bit controversial. To be honest with you, in our setting, the most important thing, as I said in my talk, is the function. If the function is okay and the minimal deformities, we just ignore it. Okay. If the patient is happy with the deformity, we just leave it. If the ulnar nerve, for example, when you're dealing with cubitus valgus, if the ulnar nerve is okay, I leave it. If the elbow is stable, I leave it. However, if the deformity is marked, okay, young girl, they are not happy with the appearance of their elbow, and then you can do a corrective osteotomy. Some literature, they do advise to do it after skeletal maturity. Some surgeons, they said whenever they are not happy with any age, they can do it. But most of the time, it's not like a routine practice in our hospital. Yeah.
Okay, Leonard. Now, I want first to indicate that we will continue responding to your question after the live webinar. And now, Leonard, a last question Can you tell us something about open supracondylar fractures? Are there, did you see them in your practice? What did you do?
I haven't seen any open supracondylar fracture in children, but I've seen them in adults. And in adult, it's very different from children. In adult, I treat them if they are clean wounds, they are fresh wound, clean wound. I fix them, orif them. If they are dirty, then I apply an external fixators. I don't put any metal work in the in the wound. But I haven't seen in my practice. I haven't seen any open supracondylar fracture in children.
Okay, thank you, Leonard. Now, thank you, dear participant, for your questions. I will give back to Leonard for the end words.
Okay, thanks, Flora. Would like to give you some take-home messages. Pediatric elbow fractures are common, and we all know it's common. Make the correct diagnosis is the first time is the most important thing to do. Early consultation is the key to a successful outcome when you are dealing with this type of fractures. And remember to do a thorough and careful clinical evaluation of your patient. We need to know the normal X-ray appearance at any different given age, because we are dealing with children who are growing. Some of them, their bones, they are still cartilaginous. Some of them, they are ossified, and that's why that slide on ossification center is very, very important, because you don't want to call something fracture which is not. It's just a physis, and you call it fractures. So you need to know and understand this. You cannot reliably see the joint surface on the X-ray because of the cartilage. Remember that small fractures can produce big problems. After reduction, the patient can be returned in the hospital for 2 or 3 days. This is very important, just to check, the circulation. Instead of sending the patient home, this patient sometimes they come from far. You send him straight away, and if there is a vascular compromise, the patient will come back to you late while the arm is already gangrenous. So keep them for a few days in the hospital and then release them after 2 to 3 days. After cast removal, there is no need for physiotherapy. Just encourage active range of motion. In the lower income countries, we do give priority to function than cosmesis. And, we prefer K-wires, over screws, because the K-wires, even in my clinic, I can just remove them. But if you use screws, then you will have to go to theater. And the challenge we have, some of us, is theater time, theater space. So that's why we like to use K-wires, because you can take them out in the clinic. Would like to thank all this team, for their input, and the AO Education Institute for allowing us to have this this talk. And I would like to say 2 more things. The first one is that this webinar has been recorded online, and it can be found on the AO webpage. And each of you will receive a survey form. Please do fill and send us your feedback, because it's very helpful. And we will continue answering to some of your questions, but it will be offline. But for now, thank you for your participation, and bye.